All right, ready to go.
Well, welcome, DBH and fellow Fresno County program contract providers. We wanted to welcome you to our biweekly Fresno County office hours with Brittany this week and Amy. Bring up a cozy drink, something refreshing to drink as we dive into CalAIMS. My name is Amy Timmons. I'm with the Managed Care URS. I'm with the Adult System of Care. My amazing co-facilitator is Brittany, Managed Care URS from the Children's System of Care. Look forward to seeing you. I'll pass it
Yeah.
to you, Brittany.
All right. Yes. Hello. I'm Brittany Storley. I'm URS with Managed Care on the Children's System of Care side. So just some reminders, just like every week, we just want to remind you to please keep your microphones on mute unless you're called upon by us to speak. If you'd like to ask a question, we do ask that you please enter that in the meeting chat, so the comment section for this meeting. And either myself or Amy, will ask for more clarification if we need more clarification, and then we may ask you to unmute yourself. We want to be respectful to everybody on this call today, and so please, no cross-talking with other participants or speaking out of turn. And then to allow as many people as possible have their questions addressed, please refrain from shouting out any of your questions. And if you have follow-up questions to something that we've said, please enter those in the comment section. We also just want to remind you all that the focus of this biweekly CalAIM office hours is documentation standards for specialty mental health services. So we cannot really respond to questions specific to SUD services, any changes to existing mental health contracts, programs, any changes to other health coverage such as Medicaid or Medi-Medi or any other health coverage that a person may have. And we can't really speak to CalAIM payment reform. Your patience is definitely appreciated. Sometimes we'll need to take down a question that you may have and may not be able to provide a response immediately. In that case, we will forward your questions to the DBH compliance mailbox or address it in next week's office hours. So we're still learning this as well, so please bear with us.
Thank you, Brittany. For us, just to let you know, as a reminder for additional assistance, you'll find the information on the CalMesa website. They have the great webinar trainings as well as the clinical documentation guidelines for peer support specialists, clinicians, case managers, and medication support. Also, for Fresno County, we try on a weekly basis to update the Q&As that you all submit to compliance to make sure that we have the updated information. Thank you so much for those who have asked questions because it helps all of us and helps sharpen all of us. I'll put it that way. So the most recent version was given on November 4th. And so today, Brittany and I will cover some of that information just to help create some discussion, but it also provides you some time. If you want to start asking questions in the chat, feel free to if you don't want to ask verbally. I know we might not be able to answer all questions, or if we do, new things come up because that happens with programs. Feel free to contact DBH Compliance at Fresno County at the ca.gov. Right. On to you, Brittany, for some examples.
All right, so to start out for today, we're just going to kind of review some of the Q&A questions that the compliance inbox has received and updated on the CalAIM Q&A document Amy was referencing. And so this was an update as of 10/28/22. So this was after the last office hours, but we thought it was a good question to cover for everyone. So PQ 38. Can both clinicians and CMHS staff, which is case management level staff, use the R and T codes? So answer, this is a great question that we are still seeking clarification on. Though there are a variety of ICD-10 codes that fall under R and T, not all are appropriate to support medical necessity for specialty mental health services or DMC ODS intervention activity for Medi-Cal reimbursement, as not all R or T codes are specific to behavioral health needs or impairments. At this time, we strongly encourage all licensed practitioners of mental health to use the following options when a diagnosis has yet to be established. So ICD-10 code Z55 through 65, ICD-10 code Z03.89, or in cases where services are provided due to a suspected disorder that has yet to be diagnosed, options are available for an LPHA or LMHP to use any clinically appropriate ICD-10 code, such as codes for other specified or unspecified or factors influencing health status and contact with health services. CalAIM information notices identified the use of Z codes only for non-LPHA staff, so that would be case management level. R&T codes are not included in that list. So for further guidance, please refer to the Cal MHSA clinical documentation guides. Okay.
Thank you, Brittany, for that update. I know that was a really good question to ask, and so thank you for clarifying that and reviewing that. The question I have is from November 4th for the CalAIMS question and answer that thought was very reasonable and happens a lot, especially when multiple providers are providing services for people. The question is, if a clinician reaches a different diagnosis than the prescriber, for instance, schizophrenia versus schizoaffective disorder, should both be listed in the problem list? And the answer is yes. Because for you, you're reaching, I realize sometimes for like instance, psychiatrists and clinicians might have a different diagnosis, and sometimes it's based on the medication that's being prescribed. And so for you going ahead as a clinician to put down what you see, because that is what you are treating. And so, but the most important thing to take away from this is consultation to make sure that you and the psychiatrist have a chance or other provider have a chance to consult about the case to see, hey, is one more fitting than the other? And so that the best care is provided for the person. Thank you.
Okay, so another question that came up on last week's updated Fresno County CalAIM Q&A as of 11/4/22 that we thought was helpful to cover was DQ 29. Do we need to develop a new progress note for each case management service provided? The answer is yes. Each targeted case management, formerly case management service, requires its own progress note. The initial TCM note would contain the TCM plan. So that's that narrative case management plan that we're putting in progress notes. And does not need to be repeated on each subsequent case management note. So as long as you have a plan, you're free to claim for case management services. If at any time that plan needs to be updated, please update it with a new plan and then continue to bill for any new case management activities that plan includes. All right, so that was it for the Q&A that we wanted to review from the last CalAIM Q&A updates.
And so we do have a question already, Brittany. So Amanda, you are ready to go for our questions. And so what is your question?
Thanks. So regarding the TCM notes, should providers be citing the date that the TCM plan was put into a progress note? So like going forward, should they be saying, please reference note dated November 10th, 2022 for the
That is
TCM
not a
plan?
requirement.
Okay, it's not a requirement.
Right, yeah, sorry. Yeah, to answer your question, that's not the only thing that's required for those notes can be found in Behavioral Health Information Notice 22-019, I believe. Or the Cal MHSA clinical documentation guide also has a list of all the requirements for that case management narrative plan. But as far as those documents state, there is no requirement for, you know, that to be referenced in any subsequent claims.
Thanks.
I would say, Amanda, it would be helpful though that they have that TCM somewhat easier to access, just so that they can refer back to it, just to make sure, hey, are the things that we're referencing things that we have included, or is it the whole new thing that we need to add into a new note? A great question, Amanda, as always. Any other questions? I was looking at the chat and I don't see anything yet. Hey, Laura, I saw that you had a question.
Yes. I read in the documentation guide given by Cal Mesa that peer services are based on the approved care plan. How can I, in the future, how can I find the approved care plan and avatar? Is it going to be in the electronic record systems that's going to replace avatar?
Are you referring to this case management plan, Laura?
Yes,
Yes,
I
okay.
am. Yes, I am.
Okay. Yeah, so it would be in a case management progress note, just like any other, you know, service claim progress note that should be in any electronic health record or even paper charts if your program has paper charts. So you would just need to reference, you know, previous claims for case management services to find that plan.
Okay. Thank you.
And Gabe, just to defer to you for a moment, because you're on. For Avatar, I know this is more in-house concern, but is there an easier access to find the targeted case management easier?
I cannot think of a way other than looking through the notes. Yeah, sorry about that. But yeah, you just have to go through the notes to look for that.
So if it's through Avatar, I would invite the team to print it out just to have access, just so that it can be easier access, just as an idea. So you don't have to keep searching for it. But also, if paper trail, if you have the paper notes, you can put it in a special location just to help you find it more easily. Thank you, Linda.
I see Rokina has her hand up.
Yes, I have two questions. One, is there a sample case management note, that initial note that can be shared with us? And two, I'm with a group practice and we're seeing the referrals from the county coming now with the assessment completed with the referral. And I'm wondering if that means our providers don't have to conduct their full assessment and we can just utilize the county assessment for that first session, confirm the information with the client, and use that initial session to create the problem list? Or do we still need to do the full assessment even though the client's just been recently assessed by the county?
Okay, so it sounds like really there's two questions there. Amy, did you want to take any of those questions?
I will take in regards to the targeted case management notes. We do not. Cal Mesa, the spirit of Cal Ames is not to have a cookie cutter, but there are the 4 sections that you can find in both 22-019 as well as the clinical documentation on page 17 that can help you with, if you have those 4 steps, that should be enough. Because really they're trying to give clinicians and case managers more, letting it be you and the person's plan. And so they just wanted those guidelines. So we don't have an example. And then for the assessment portion, you were talking about so for Cal Ames, really, you can provide a service prior to an assessment being completed. So let's say the person is referred to you, but it becomes very evident that they're needing something right away. You could provide targeted case management. The assessment, I would invite you to look at it, because let's say it was referred by the county, but it was done by urgent care wellness, so they only saw the person one time. As you get to know the person, you might find more diagnoses that you would want to update and change. And so to make it more fitting for what you see with the person. But I'll pass it to you, Brittany, if you want to add anything.
Yeah, so this actually is something that's been in place for a long time. You know, everyone under the Fresno County mental health plan umbrella, whether that's an organizational provider or a group provider or an individual provider, all of our assessments and treatment plans are interchangeable with other providers. And so if you're getting referrals with an assessment, that's great. Now you don't have to ask for it, so that's awesome. But you can definitely utilize that assessment as your basis for treatment. Just like you said, Rohina, would 100% make sure you go over that assessment with the person you're serving, make sure the information is still current and accurate. And, you know, if you feel like maybe there's some information missing, you can definitely do your own assessment. There's no rule that says you can't. But if you feel like it is great and it's a good basis for you to provide your services, feel free to just document that you reviewed that with the client, and then, you know, continue on with creating the problem list.
And I was going to add also because I know you totally want to be client centered. And so if someone just did an assessment with Fresno County, as you know, they might not want to send the whole thing again. So totally respect that. And great question, Rihanna.
Thank you.
All right. I love all the questions. Definitely, you know, if you are thinking of any, put it in the chat so that way we can, you know, make sure to get to it. So we do have a question from Holly in the chat. It says, moving forward for new youth, it will be the first case management in the chart, and you can filter case management in Avatar for progress notes and scroll to the earliest one. That doesn't help with existing youth as much. So I think, Holly, what you're referring to is for those who use Avatar as their electronic health record, if it's a new youth and a newly created case management narrative plan note would be probably the first case management service. And so it'd be easier to find that versus maybe youth who have been in services for a while. Is that correct? Yes. All right, yeah, so that's just for those of you that do utilize Avatar as your electronic health record. We know many people on here do not. So your organization may want to come up with your own system to figure out how best to identify those notes.
Great points, Brittany. Thank you for that. And I love the spirit of like problem solving. It's great to try to make it the most convenient for people. Are there any other questions coming up? Looking in the chat and then looking to see if I see any hands.
This might be a very short office hour session today. Maybe that means everyone is feeling a lot more comfortable with CalAIMS.
I also recognize Cal Mesa performed, had a lot of great office hours. And I know, like you said, Brittany, that when reaching out to providers, it's great to see that they have some feeling more comfortable. Holly, you asked another great question. Do you have any recommendations for how to help clinicians determine if services are medically necessary? So medical necessity and access are going to be a little bit reversed with CalAIMS. So for access, it's more do they have the requirements? And so for the 21-073, it talks about for the access for children in particular, it's kind of a little bit more lenient for children under 21, but for kids that if they have experienced trauma, if they have experienced, let me get to it so I can correctly respond to it. So for children, if they have been, if they're placed in a high risk for mental health disorder, such as trauma, or if they, in their scoring with the CANS, that they are high risk for homelessness, or they've been involved with child welfare system or juvenile justice involvement, then they would qualify. Or if they have both of the following requirements, a significant impairment, a reasonable probability of significant deterioration in an important area of functioning, a reasonable probability of not progressing developmentally appropriate, and a need of specially mental health services. So these would be permissible to have access for especially mental health services. For medical necessity, that's more determined on what kind of services will be provided for the person. And so depending on the person's level of needs, like if some families might be a little bit more resourceful, they have a lot of family support, they have community support, but for those who might be homeless or in welfare and struggling, then working with the families, they might need more case management and additional supports. And depending on if psychotropic medication is necessary. So I don't know if that helps or not.
Yeah, do you want to expand on your question at all, Holly? Is there any like specific examples that you're thinking of?
Excuse me, I was just trying to think of a way to help clinicians make determination of which services are needed to address which diagnoses, right? Like you just explained, homelessness would need some case management, but it might not necessarily need therapy unless there's something else going on. So things like that I'm helping clinicians to change their thinking about things like that.
Sure. Yeah, I mean, like Amy had mentioned, medication services. Obviously, we know not all of the people we serve need medication to address their mental health issues. And so that would be, something that a clinician can always refer to a doctor if they think that that might be an option for the person. But obviously, then the doctor can determine whether or not that service would be medically necessary. There's a few other services such as ICC or IHBS, and we have that eligibility form that everyone should be utilizing with youth to determine if they qualify for those services. And then it would really, even if they do qualify, still be based on the clinician's own clinical discretion or whether they or not they feel like those services would be necessary or helpful for that specific person or that family. So it is kind of left up to, our own clinical discretion with the people that we're serving and what we think, might best benefit them in addressing, their symptoms or diagnoses. You're welcome.
And Marina, do you have another question?
I do, and I'm not sure if this is the right forum, but given that CalAIM has made it more possible for us to work with clients with the no wrong door policy who may not need our level of care initially, but we're, serving them and whatever their needs are. Our group practice anticipates an increase in case management services, and wondering if there's any discussions about modifying those rates for case management, as those are pretty low for individual and group providers. Do you know if there's any discussion around that?
I will defer to Carla.
Hi there. So that is not related to CalAIM documentation, so we don't have the answer to that. It may be something that you would want to discuss with contracts and also for consideration if it may be affected by payment reform, but that is not something that we would have that.
Thank you.
Marina, great question, and I'm glad that you're thinking about that. And great question for the contract, as Carla has said. Hopefully they can get that going so that you feel more supported too.
Great. Any other questions for today? Not seeing any in the chat, or there's no hands up. Rohina, I see you asked who would be the point of contact for contracts. Well, it would depend for individual and group providers. You have an assigned staff analyst from contracts, although I do not know who that person is off the top of my head. But I know you guys are on the individual and group provider master agreement, which actually I want to say that managed care kind of oversees that as well. So, and Francisco, I see you're on here, feel free to correct me if I'm wrong, but it would probably, you could reach out to managed care to speak with John Rogers or Meng Mua. They might be in charge of overseeing that.
Also, I see Allie Jordan's hand up.
Well, go ahead. Francisco is going to say
I
something.
was,
Oh.
I was just gonna respond. Yeah, you could email John Rogers if it's a actual contract issue. There is an assigned analyst and we can, do that, but I would start with John Rogers.
Allie?
The assigned analyst is Elizabeth Aguirre. She, as far as I understand, yes, it's a joint effort between managed care and contracts. I'm not sure if it would be Elizabeth or John who would be more helpful for this specific issue.
But
I would
yes,
start with John, if it's administrative, it would be deferred over to contracts, but if it's a related to services, it would go to John Rogers.
Lupita, can you put John Rogers' email in the chat to help Raina, just to make sure it goes to him?
Yes.
And I'm so glad that you're asking these questions because I think all of these will be helpful for people, because, you know, this is going to be a common thing probably coming up. So appreciate it. Thank you so much, Lupita. Any other questions?
Well, hopefully our lack of questions means that everyone is feeling more comfortable with CalAIMS and the changes that has brought to our system. And if you do have questions, you know, further down the road, you definitely can submit them to DBH Compliance. And we'll be happy to, you know, answer those questions and they'll appear in the next CalAIM office hour updates.
And our next office hours will be on December 1st. And I just wanted to say, if there's no more questions, I'll give a couple more minutes. But I really hope that you all have a great long weekend, for those that can. But also, Brittany, thank you for being an amazing, fabulous co-facilitator.
Yes, Amy, thank you as well. All right, well, I'm not seeing any more hands or questions, so I say we call it for today.
Thank
Thank
you all.
you
It was
all for
great to
joining.
see you.